Who is the system actually designed to serve?
So I have the 5 dynasties and the 5 healthcare families. The 5 families are the insurance carriers, and the 5 dynasties are the nonprofit health systems, including the academic centers. That's who it's absolutely designed to help. And then below that, you've got med device, you've got pharma, and you've got kind of AHIP, the guys that run insurance. But structurally at the top, those 10 groups is really who it's designed to help. And when you look at who's supporting those 10 groups, it's largely, and unfortunately, it's the Centers for Medicare and Medicaid.
Remember when the Affordable Care Act was supposed to make healthcare affordable? Lower premiums, better access, doctors who could spend time with patients. Yeah, that's not what happened. Today, we're talking to someone who's been inside the system, running companies, analyzing money, and he's going to explain where all those promises went, who actually benefited, and what's being done about it now. Welcome back to Vital Discourse. I'm Dr. Lee Mandel, and with Dr. Ben Salento, we're joined by someone who has become a sharp and increasingly influential voice in the business of healthcare conversation, Dutch Rojas. Dutch is the host of Rojas Report podcast. Dutch has built a reputation for cutting through the usual talking points and focusing on what actually drives healthcare in this country. Incentives, control, pricing, power. He's written and spoken extensively about physician autonomy, consolidation, transparency, direct contracting, and why so many independent doctors feel like they're practicing inside a system that's designed to weaken them. We're really glad to have you, Dutch. I want to start with the big picture here, because your view of healthcare is actually a little bit different than the kind of that standard broken system narrative that we hear so often. Many people describe healthcare as dysfunctional or broken. Your argument's a little bit more provocative, I guess I would say. You seem to suggest it's actually functioning exactly as its incentives tell it to. What do you mean by that?
I think if you study structure and architecture, you understand the difference between a rigged market and an actual market. And I think it's pretty plain to see that our healthcare system was never really designed for the benefit of patients. Certainly wasn't designed for lower prices or higher quality outcomes. I think it was designed to keep people sick, to keep people in pain, to keep people buying more prescriptions. And certainly it wasn't designed to help physicians, nurses, or any of the wonderful medical staff that we talk to each and every day. And so that's a large part of what I talk about, because it's so important to reframe the conversation. You know, you hear it all the time, well, it's broken. Yeah, I just don't think it is. I think this is exactly how it was designed. And whether you read about the history of Wall Street, whether you read about the history of the American Hospital Association, the American Medical Association, you read about the history of certificate of need laws, you read about the history of how Medicare started, how did Medicaid start? And when you begin to start actually reading, you begin to realize the formation of the structure, the influence of policy and business, and then how we ended up where we ended up. And I think that's really important for people who keep asking, why does the system do what it does? If you ask them, as a general matter, most people will say, no, I don't know how we got benefits. I don't know why employers are stuck with them. I don't know why lawmakers make these rules. And so I think, once you begin to understand those things, you'll begin to see the real structure of it, and you'll see how it was always rigged. And by rigged, I don't mean it in a nice way. I mean rigged in a very unkind way.
Yeah, I figured that.
The people in charge, whoever they are in their particular section, designed it this way to extract maximum amounts of revenue from the American people.
Okay, so then tell me, we're talking a little bit more in generalities. Who is the system actually designed to serve?
Well, I write about it a lot. So I have the 5 dynasties and the 5 healthcare families. The 5 families are the insurance carriers, and the 5 dynasties are the nonprofit health systems, including the academic centers. And that's who it's absolutely designed to help. And then below that, you've got med device, you've got pharma, and you've got kind of AHIP, the guys that run insurance. But structurally at the top, those those 10 groups is really who it's designed to help. And when you look at who's supporting those 10 groups, it's largely, and unfortunately, it's the Centers for Medicare and Medicaid.
And Dutch, you can trace that back to the passing of this to the lobbying that went on to actually pass it. If you look at the ruling by the Supreme Court in January of 2010, that had to happen before the October passing of the bill in 2010, because over $270 million flowed almost immediately. Once they took the corporate cap off a $100,000 contribution, money flowed into the foundations of our politicians, and suddenly you had the meme that shook the world in terms of our world, which was, we have to pass it so we can find out what's in it. Which of course is the definition of a stool sample. But it's exactly what they used to sort of convince people that, yeah, we got to do it. And it actually unmasked how things are done in this country. I mean, money flows to you. You don't know what's in it, but it becomes a good idea because money is free speech.
So let's take a step back for a second. Dutch, tell us your story. Okay, we know that you're a Marine. We know that you became a healthcare entrepreneur. How did this all happen?
Yes. Look, I was born and raised in the Netherlands. My typical family. My father is an American. I should say his parents were immigrants. My last name's Rojas. I mean, that's not hard to figure out. He worked for British Petroleum for a lot of years in the North Sea. Met my mother, beautiful blonde hair, blue eyes Dutch lady. You know, I mean, like, who wouldn't fall for her? She's still beautiful. And they got together, and my father said, you know, son, the land of freedom and capitalism is in the United States. And I think he realized that I love the Netherlands very much. I'm very tied to the country of Holland. I'm actually from what we call South Holland in Rotterdam. And I love the Netherlands. There isn't anything about it I don't love. It's my first language. My family lives there. However, if you want to be free, if you want to work hard and you want to achieve the American dream, which I would say is a dream for every person in the world, right? Who doesn't want to have their own house? Who doesn't want to live autonomously? Who doesn't want to be left alone just to work and help and love their family and love their community? That's what I wanted. And I didn't see a path for that in the Netherlands. In the Netherlands, whether we admit it or not, it's still a caste system. If you are born to X, you will be X. And if you're born to Y, you'll be Y. Now, a little bit of that's changed over the last few years, but it's only been the last few years. Before that, if you were born in a great house in the Netherlands, you got to go to university and be in a great house. My chance was I played soccer, and I was terrible at it, by the way. I don't know how the Americans decided that I was any good at it, but they did. And so I got a little bit of a scholarship to a Protestant university called Oral Roberts in Tulsa, Oklahoma, the fall of 1993. And I did that. And I loved it. I had a great time. But about my middle of my sophomore year, I decided I needed some discipline, and I joined my beloved Marine Corps, and that changed my life forever. It was probably one of the greatest decisions I ever made. And I certainly recommend it. You know, I mean, of course, Dr. Ben's going to say the same thing, but I recommend it to young guys. So, yeah, I got an undergraduate degree in accounting. I did finish. I did my graduate work in finance, master's degree in finance. And so no MBA. I don't like MBAs. I'm glad you got a law degree, Dr. Mendel. I don't like MBAs. But yeah, I mean, basically that's it, right? And I the long story is, and I've told this story several times, is at Oral Roberts, you have to go on a mission trip. And so I decided that my mission trip would be to South America, and that I would volunteer at these portable ambulatory surgery centers. At the time, of course, I was 22 years old or something. I had no idea what an ambulatory surgery center was. And what I saw absolutely changed the direction of my life. If I was going forward, I immediately went 180 degrees. Because what I saw dentists, general surgeons, ENTs, specifically, anesthesia or anesthesiologists, and I saw them working 24/7 at these camps on the Amazon helping Amazonian miners. And this was a religious thing, but it was really portable ASCs and dentistry. And they fixed cleft lips, and they fixed mouths, and they fixed babies. And what you saw was, and Dr. Ben really can envision this because he's been through a bunch of the same stuff I have. But just imagine like you're on a mountain and there's just people everywhere, and they're walking out of the jungle into the plains, and they're saying, "Can you help my kid? Can you help my child?" And I watched grown men. I remember I was 22 at the time. Grown men cry. I watched a female dentist just weep and break down and say, "This is kind of what I was designed to do."
Where were you, Dutch?
Guyana.
Guyana? Wow.
Yeah. So we took a bush plane. Then we took a two day boat ride. Right. So we were probably on the boat 7-8 hours, something like that. And I mean, beautiful. But you're in the middle of nowhere. And what you realize being a Westerner, I for sure did, was one, be grateful every single day for everything you have. And what's the trajectory of your life? And you're asking yourself things as a young person that you've never asked yourself. Now, the good news was I'd been in the Marine Corps. I'd done my active duty time at that time. And so it was kind of like I felt like a little bit of a grown up. I'd already humped some mountains. And so I was like, okay. But then the emotion got involved, and I'm a guy and I have no emotions. And so, it was a drastic pivot for me where I went, okay, I'm going to finish as an accountant. How can I be a part of this world over here? Like just the goodness of it, the humanity of it. And, a few years later, I ended up helping a bunch of physicians start working on ASCs. So like, I just think, purpose, mission, all of that kind of comes together, whether you try to run from it or not. It just kind of happens. I mean, how does a Mexican guy end up with a Dutch wife? And then they send me to school at a Protestant school. I wasn't Protestant. And it's like, how does all this happen? And then you go on a mission trip. I didn't want to go. And you kind of, when you look back at both of your lives, you just see kind of like, how did I get from here to here to here to here to here to here to here? I mean, how did Dr. Mandel end up going to law school? I mean, you already got through medical school. You wanted more
That's
pain?
a great story, actually.
I know. I'm like,
But that's the beauty of America is that is like you said, there is no caste system. We all have an unbelievable patchwork history that brings us to the present. I love it.
That's right. You know what? I'm going to steal that. I hope you don't mind. I like that patchwork because it is all of the things that give you what you have today. I do a reflective piece on the Rojas Report on Sundays, and this week was more about what did you think at 15, 25, 40, and now I turned 50 this year. So I was like, okay, well, this is pretty revelatory. Like 50, you got kids, you got houses, you got wives, you got businesses, you have bills. Like you've been through a lot of pain. You've been through lots of rewarding moments. Like what's all that like? I mean, pretty amazing to watch, pretty amazing to see and figure it all out.
It's kind of like that Matthew McConaughey speech at the Oscars. Who's your hero?
Yes.
My hero's me 10 years from now. And how about 10 years from now? No, it's my hero 10 years after that.
I love that one. And I like did you see the Roger Federer one?
I did.
His commitments.
Yeah.
Those two, I was like, I could just watch those in the mornings and then I'd be like, okay, all right, rah, 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 let's go, buddy. Like you got to get it together.
Okay. So how did we get to healthcare commentary?
Okay. All right. So I was at KPMG, right? Tax advisory. And I went to work for a REIT. I left KPMG, went to work for a REIT. And a REIT is a real estate investment trust. I'm an accountant. So I was doing the acquisition and disposition work of what it looked like when we invested in hospitals, particularly in land that we sold and leased to hospitals. So we had land in Long Island, we had land in Florida, we had land in Arizona, we had land in California. And basically my job at the Real Estate Investment Trust was, what does this all look like in the future? So if we deploy capital, raise capital, deploy it, and we buy these land holdings and we put a hospital on it, how much money are we going to make? Well, through that work, it took a couple of years. I was living in New York City. And then amazingly, I started meeting physicians like you. And my world got turned upside down because then I met Scott Becker and he was like, hey, why don't you come to this ASC conference that we have? that's the third week of October every year. And so I go to this ASC conference and I'm like, doctors are trying to build this. What is it? Like, just the formation of the thoughts. And so this is in 05, 06. And you're really trying to get through, why are physicians building these things? And then why in certain states can't they build them? That was completely eye-opening to me. Like, what is certificate of need? Why doesn't it work? Because I'm living in New York City at the time. So I'm like, why doesn't New York City want us to build more of these? Like, what's the problem here, right?
Especially when they're so efficient.
Right. And then why in California are they allowed to build as many as they want? And everybody knows there's more ASCs in California than anywhere else in the country. And so that started me down a path. Then I met a bunch of docs, and they were all kind of probably my age now. And they said, well, why don't you come to work for us? Why don't you help us start figuring out this ASC development business? And I was 29, 30. And I thought, this is the greatest thing ever. I don't have to work for a large employer. They won't tell me what to do. And of course, my parents were like, having a job is really important. And you live in New York City, it's very expensive. And so the day that I thought maybe I'll tell these physicians, which was a really funny story, I'll tell them no because I need to stay in my job and earn my living. The REIT sold to another company and they were having some challenges. But anyways, I got paid out. And so all of a sudden I had a little money in my pocket and I thought, okay, well, I'll take the chance with these doctors. And that opportunity led me to another one, which was really the big one for me, which was I got to work at Arizona Pain Specialists, which became Pain Doctor. And then we got to develop ASCs in 17 states. And the transition from Marines, finance, accounting into healthcare was pretty typical, I think. It's just one job to the next. And then I don't know how long it took you guys, but at some point in your medical careers, you were like, well, what's this friction? Like, the question is, when did that happen?
So what were the promises of the Affordable Care Act? Access to health care. Those who are underinsured or uninsured would be able to get health care, and premiums would go down. What did we get from the Affordable Care Act? None of it. Premiums went up. We were promised that we could keep our doctor. That didn't happen either. We're going to go through in today's podcast all of it. It's a long podcast. We're only going to go through about 2% of all of this, but bear with us. You will really want to hear what's going on.
Nothing seems to make sense, right? In every venue, so the economic portion, nothing that you learn in business seems to have the same mechanisms, a mechanistic equivalent in medicine. So it doesn't seem to work the same way as a capitalistic society. It works almost the opposite. And also the pressures on efficiency. Like if you forget about economics and you look at efficiency, why aren't the most efficient systems the ones that we stand behind? Why do they seem to be sort of pushed down and inefficient systems are bolstered and encouraged? It's real strange.
Yeah, look, I think, one of the moments that really hit me hard is we were negotiating with Blue Cross Blue Shield of Arizona. And I realized, we had no leverage. And to be very specific, I realized we had no structural leverage. And I thought, none. Okay, so these guys I work with, they're not bad physicians. In fact, they're really good. We're basically getting just par Medicare. We're killing it. We're doing so well. People are having good outcomes. We have all of our own equipment. We've built our own surgery center, and yet we're still being punished by the payer. And, it just didn't make sense. And I think when you have that little aha moment, I'm doing exactly what the insurance companies want. I'm doing what Medicaid wants. I'm doing what Medicare wants, and yet I'm being reimbursed less and less and less and less. That really hit. You might as well just hit me with a bat, because I went, wait a minute, this doesn't make sense. And then I started studying. Then I started going to Washington. I started studying Medicare reimbursements. I didn't know there were 9 fee schedules at the time. Now there's 12. I didn't know anything about the RUC committee, right? I started learning, and I was like, wait a minute. Okay, well, this doesn't make any sense. Why is the central planning office deciding what doctors get all across the country? And then why does a doc in Dallas get less than a doc in Phoenix. And why does the doc in Phoenix get significantly less than the doc in LA? And they're all like, oh, no, but you're getting 100% of Medicare. And I was like, this makes zero sense to me.
Well, it also changes. It's moving goalposts too, because sometimes they'll tell you when they're talking about, different, like the difference between a Latera implant and an actual open surgical procedure, they'll give you more for the open surgical procedure because it's more work.
Yes.
So you say, well, so wait a minute, I'm getting paid more for the complexity, but then in other venues they're like, like the Inspire implants, incredibly technical and complex, and you get $500 for it. So nothing makes sense, and they don't use the same metric across the board. They seem to change it to fit their narrative, whatever the pay reimbursement they want to have. They seem to sort of change how you're getting the thought process on how you're getting reimbursed. So it's moving goalposts.
I couldn't agree more. We hysterectomies are done one of the top 3 most common procedures in the country. And we started looking, this is, 15 years ago. We started looking at data between laparoscopic and open. Well, the reimbursement in most states was like literally 1.3x of laparoscopic. And then you start looking through all the data and you're like, was it really a good idea to put 600,000 women through open when we could do laparoscopic? Like, how do we make these determinations? But when you get to it and you start seeing the weighted averages moving past a normal distribution, your math brain goes, man, this doesn't feel right. Now I can't sit in all 600,000 surgeries and make these determinations. 1, because I'm not a physician, I don't make medical determinations. But 2, no one ever says, well, let's explore that question. And I've asked, and it's not being done. And so I sit here with my conspiracy theory where I go, okay, out of 600,000 women, how come in this segment of the population we did more laparoscopic, but in this segment where you guys are getting 1.3x the reimbursement of laparoscopic, we're doing more opens. It just kind of, the math just kind of tells the story. So I very much understand that. And I think I try to share with the young people, like, ask more questions. Don't come to conclusions. Keep thinking. I talked to Policy Wonk on X about it the other day. He kept saying, I've had these ideas since I was 22 years old in undergrad, and he's like 25 now. And he goes, I've long held these things. And I go, you haven't long anything. And I go, I'm not rebuking you. Understand the inherent lesson. Like I'm saying, like, take the long view. And I think, the 3 of us are a little older. And that's what happens is at 35, I didn't feel like I could speak out. At 40, I didn't feel like I could speak out. I think in the Marine Corps, it's a hierarchy of rank. In medicine, it's certainly that way. And I think I always tried to be respectful of that. Like, when can I speak? When can I not? I tell people the first 5 years of my career, I don't think I said 8 words. Like, I just listened and said yes sir, no sir, or yes ma'am, no ma'am, because that's the way it needs to be. You need to absorb. But once I got to 44, 45, and I'd had a couple of exits and I'd had some money in my pocket, I went, okay, now I'm going to start talking, right? And so the journey on the social media end started really probably 10 years ago, where I went, no one that I know is having these conversations yet. When I get into the doctor's lounges at ASCs and surgical hospitals around the country, like we're having these every day, there's no carrier's going to come after me. Like, what are they going to do to me? Right? No, like, they can't do anything to me. I understand the retribution to physicians and I understand the risk. So I just said, well, I'll just do it. I'll have these conversations. They're hard conversations. It's like rounds coming down range. I don't appreciate being shot at, but like, I've been there, done that. So, okay, like, I'm going to return fire now and I'm not going to take any more. I'm going to start fighting back. And what you realize is, even at 1 million physicians and the people that support the independent practice of medicine, there's not very many of us. There's significantly more of them. They have a much larger fighting force than we do.
It's so easy to silence physicians. It's unbelievable. We're terrified of our licensure. We're terrified of our reputation. We're terrified of getting delisted or thrown off of panels for insurers. there's a million ways to get us to stay in line and not make waves.
This is why I wanted to encourage docs not, like, I know we're going to talk about it later, but I just think independent practice is coming back. And I think it's going to come roaring back. Oh, it's going to be so great.
I think that everyone's ready for it. I think that the best way to go about that, though, is to first understand where we are right now, which is kind of what we're hoping for with the ACA, the Affordable Care Act. I mean, set some parameters there. When we started in 2010, right, we were around $2.3 trillion for total medical expenditure, and we're well up over $5 trillion now. So there's a 220% increase in general. And so
before we get too far into the weeds, I just want to unpack a couple of things that you were talking about. First, some of the people that are watching this might not understand some of the terminology. So you talked about the RUC. Okay, I can tell you that 90% of docs have no idea what a RUC is. Okay, or how it affects their practice.
Can you describe the ruckus?
So you can tell us what the RUC is, and can you also tell us maybe why different doctors in different areas are getting different amounts to do the exact same thing?
So the RUC committee is endorsed by the AMA, set up by the American Medical Association, and it makes the determinations on relative value units. So it decides, there's a group of 32 people, 30 specialists, 2 primary care doctors, and it decides what the relative value units are, or the equivalents are, for every single procedure that every doctor performs in an RVU basis. Now, if you're an independent practice and you don't have RVUs, or you're in a cash practice and you don't have RVUs or CPTs or DRGs for that matter, none of that matters to you. But anyone that works in a health system or a hospital deals in relative value units. And so it's very important, because specialist, it's a zero-sum game. There's 100%, and then it's divvied up between all the specialists. And as you know, vascular surgery, neurosurgery, and ortho, some cardiovascular surgeries are the big 4 specialties. And so they get a lion's share of the cash, because what Dr. Ben said was, it's based on complexity. It's not based on outcomes. It's not based on money. It's not based on anything else other than those 4 items. Now, I do get a lot of pushback, docs, to be fair. I get a lot of pushback like, hey, this is the best we can do. In other words, central planning is the best we can do. And my pushback always is, well, that's not how markets work, right? And we can have a whole conversation about markets. But if someone doesn't know anything about the RUC, I would encourage them to look it up, study it, understand it. The probably the biggest challenge there is doctors get together in a room. By the way, it is open to the public if you ever want to go to a RUC committee. Now, what I learned was, because I've been, is you do have to ask permission several months in advance to go. Because I asked permission like a week in advance, and they were like, Dutch, you cannot attend this open meeting. That's open to the public. You can't attend. So, yeah, but the I guess the point is, what happens? So once the determinations are made on what the RVUs are valued at, then those recommendations are given to CMS. And this is where I have a problem. CMS, Centers for Medicare and Medicaid. This is where I have a big challenge, is CMS unequivocally takes these recommendations and deploys them throughout the United States. There's supposed to be an arbitrary conversation where someone says, no, we're going to have a conversation about these recommendations through all of CMS. CMS has almost 7,000 employees. You're saying to me that 7,000 employees totally agree with 32 doctors? And then we're just going to take central planning from the 32 doctors who represent a myriad of associations. By the way, I don't think these physicians are bad. I've met probably half of them. They're not bad, but the structure and the system is inherently anti-physician and anti-patient, and that's where.
And but also, how do you know where these docs are, where their heads at, where they're coming from, where they stand politically, and who can influence them and how? I mean, is that looked into at all? I mean, obviously they have opinions on things, and so it seems kind of arbitrary for the 30, hundreds of thousands of physicians in the U.S. that 32 randomly chosen ones are deciding how we get paid.
And are they practicing physicians or are they glorified administrators?
We know the 32 are not randomly chosen, right? They all come out of an association of their own specialty. And they tend to be the policy wonks. I mean, one of my good friends happens to be on it. And I mean, he's smart. He's great. He's a good dad. I'm like, he's all the things that you want. My issue isn't with him. That's I would call that a second order issue. My first principle issue is with the RUC itself and with CMS itself, like what the breakdowns are there. Yeah, and I and it's tragic that people don't know these things. I know that part of what this podcast is trying to do is, hey, let's lower the veil. Let's move it aside and let's tell people the underpinnings. Because as a human being, it bothers me that 32 doctors are making these decisions. And they'll all say, well, CMS can override us anytime. And then I go, well, what's the evidence that CMS has ever overridden anything? Well, it's never happened. Okay, well, I mean, then they have decided, then they are the kings, and that is the rule.
And there's no appealing it.
What do you mean by appeal?
Well, appealing the rule. They make the decision. Independent physicians certainly have no way of having any.
We have no leverage at all, to your point.
Or leverage in changing that decision.
Do you have a $40 million house down in West Palm? I mean, like,
I do not.
The neighbor, if your neighbor's Dr. Oz, you might,
Right.
I mean, the answer to your question is no, there's no appeal process. There's a really good arguments process through the inherent intrinsic process that they go through. And by the way, I'm not saying anything bad about that because I do think they argue really hard. My problem is the process itself, the structure of the thing. Like, I just don't like it. I want market pricing and market structure. That's what I want. I want to be able to shop for healthcare like I shop for anything else.
And so why the difference in payments to physicians depending on where you are in the country?
It's all based on cost of living.
So again, that's what I was talking about before, Dutch, where you keep changing the goalposts. It should be based on complexity and outcomes and the desires and efficiencies of the places that you're working and the patients you're working with. But then all of a sudden you introduce the thing, well, they live in New York, so they got to make more for it. I mean, you should
nonsense.
If it's based on if it's based on complexity, and I'm doing a very difficult surgery and I'm getting great outcomes from it, I should get meritocracy. I should get more money for it. Shouldn't matter if I'm living in New York or not.
I do think that we're going to begin to see that. I think that the federal government is going to be forced into studying a little bit of statistics and understanding what reversion to the mean actually means and what's going to happen. I think we're going to see some pricing dynamics occur, even though that's not their intent or their plan. But if you're on traditional Medicare and you're getting a joint replacement and you live in a beautiful apartment in New York City and you've lived there your whole life and you're like, New York City doctors are the best. Even though that may be true, right, that belief, what's going to happen is the internal economic pressure of the federal government is going to say, what are the 10, 12, 15, 30, 50 places in the United States that we can essentially send people to do joint replacements? Because we're spending the variance in spend between these regions is too high, right? So I'm going to pick on Atlanta, Dallas, Houston, or I should just say like Georgia, Texas, even parts of Southern California are significantly cheaper than a Boston, than a New York, than a Chicago. So, and certainly in Michigan. Michigan's crazy expensive. And so what happens when the federal government realizes that? Will they be supporters of paying twice as much? And by the way, we're not talking about pro fees. We're talking about facility fees only. Are they going to be supporters of paying twice as much? Or are they going to finally go, you know what, there's a really good group of orthopedic surgeons, and what if we just let them do it? Like, what if we built kind of areas of the country, right, that have naturally kind of come up that people go, okay, well, let's just say, for example, you live in New York City, but in Princeton, New Jersey, we built the most amazing orthopedic factory that you could ever build. I know I called it a factory, but you understand the idea. And people from New York City just took the Amtrak because you can do it in about an hour and a half. And you're in one of the most beautiful...
Can you back up, though, for a second, Dutch? Because you went over it really quickly. You said something that's incredibly important to me, and I know a lot of physicians, and probably what some physicians and most patients don't understand. You just said pro fees, not facility fees. When you say that it's more expensive or less expensive, break down the relative percentage of the cost of healthcare. Let's say doing a procedure. The biggest expense there is not the doc. The surgeon's not getting it. Break down what it means to have a certain cost for a procedure. Who's getting that money? Where's the money going? And why has the cost exploded? Has it been in one percentage or another inside that block?
Well, we're really getting into the weeds now. This is the fun part.
Yeah.
This is the part I like.
This is the part that people don't understand, and it's 100% of what's happening with the explosive cost of healthcare.
Well, it's also why I fight people with verbally, not. Well, I guess if I had to, but you know what I mean, verbally. I spar with them because they say, these physicians are all rich. The physicians just cost all the money, blah, blah, blah. And it's all these famous people on LinkedIn and Twitter or X. And I just go, you're a complete moron. You're a doofus, and you made money in tech, and yet you never paid attention to basic bar graphs, right? And so when we look at facility fees, which have basically come into popularity over the last 20 years, what we see, and by the way, this depends on market. It certainly depends on your ability to negotiate, but let's talk about Medicare. So when you look at facility fees, they are generally 50 to 65, 68% of any procedure, right? So the doctor's getting very little. Anesthesia, when they're involved, are getting very little. Now they're getting more in the last 2 years because anesthesia is just blowing up. There's just not enough, right? Everybody's seeing that. Implant gets a little, but the bulk of the money, the 80-20 rule, is facility fees dominate the cost. And health systems will say, well, Dutch, you're an accountant. You understand accounting. And I always say, yes, much better than you. And the thing is that, yes, they have to pay for nurses. Yes, they have to pay for all the equipment. Yes, they have to pay for the OR. Yes, they have to pay. But the way that the law and the rules and the regulations are distributed by CMS allows us to arbitrage. So if I'm a banker on the health system side, I'm allowed to use these facility fees to do things that they were never designed to do. Like 10 years ago, I could be a health system CEO and I could buy every independent practice within a 60-mile radius, and I'd have a break-even point of like less than a year and a half. Because I could just arbitrage all of the facility fees that before weren't allowed to be collected or reimbursed. And now I, as a nonprofit health system or even a for-profit health system, could then deploy facility fees, and then I could capture all this cash. This is why we said at the beginning of this podcast, it's not that it's broken, it's that it's rigged. Because the lobbyists
to work that way.
Yes, the lobbyists. Yes.
So from 1997 to 2007, physician reimbursement went down about 35%, but facilities fees went up over 900%. And the same type of issue happened from 2010 to 2020. They're just exploding out of control. Just to go over it, facility fees means the amount of money that you are paying to a hospital, an ASC, something like that. And then the professional fees he's talking about is payments to the person doing the surgery, the surgeon.
I mean, if you like we talked about total joints. A total joint reimbursement by Medicare, let's call it, I don't know, $21,000, $25,000 in a really expensive market. Doctor get $1,200.
Yeah. Most patients don't understand that.
Yeah, I know. That's why I'm like shouting as loud as I can for as long as I can.
It's a lot of work doing that.
Because I go, wait a minute. The guy just did a 45-minute procedure, by the way, flawlessly, with less than a 1% readmission rate, and you're giving him $1,400. And the hospital gets the rest.
Out of a total 25 or 26,000. That's all they're getting.
Yeah. And you're wondering why the guy in Morristown has a jet and a helicopter and a fourth house in Naples? Like, I don't know what planet we live on. It just doesn't make sense. We're not caring for the patients, and we're not caring for the physicians and the clinicians that take care of those patients.
Can I ask you a question then, which is something that I've always wanted to get a take on outside of my own impression? Do you believe that the authors, and what we should go into who actually wrote Obamacare, ACA, do you believe that this system was designed to sort of push money into certain areas as a bit of a payoff, and at a certain time collapse and usher in single-payer healthcare? Is that, a lot of people say that. Is there any sort of truth? Is there evidence that, from your perspective, is there evidence that that's true?
So, and I guess in a wider sense, why did we need the Affordable Care Act? What was wrong? What were they trying to fix? And to Ben's point, is it that they weren't trying to fix anything, they were trying to push single payer?
Okay, I think this is where students of history will really benefit. Remember, at the beginning of the podcast, we had a discussion about history. And I think, coming from the Netherlands, I'd learned a little bit about American history, but I really didn't know it. I remember sitting in my freshman 101 or 100 class on American history, and all the kids were like, oh, this is super easy. Christopher Columbus, blah, blah, blah. And I was like, well, who the Hades is Christopher Columbus? Like, I don't know who that guy is, right? And I'm like, hey, I'm from a little province over here called South Holland. Like, I don't know this stuff like you guys do, right? But one of the things that's really important is reading history. And so let's just take a moment and think about, I was in college 93. Well, I graduated high school in 93, went to college in 93. And you think about what was going on in that time, and that was really probably the last quarter of bank consolidation. And so in the late 80s, early 90s, what you saw is that you went to the ATM, and the next time you went to the ATM, it was a different bank name. And what happened was a couple things that are really important to this discussion on healthcare. I'll make it really brief. But what happened was banking was all intrastate, meaning you did not have interstate banking before consolidation came in the late 70s and early 80s. And so if you were a bank in Texas, you were allowed to be a banker in Texas. You were not allowed to have a bank in Oklahoma. That was not allowed. You could not have two banks. You could have one. And it was a bank in Dallas. It was a bank in Houston, Austin, San Antonio, El Paso. If you decided, hey, I'm in Dallas and I also want to be in Shreveport, well, that required a totally different charter. It required different rules, different regulations, right? Because you wanted to be in Louisiana, which is an hour away. Well, what happened was the guys at the Federal Reserve and the largest banks, some of the larger bankers in the country said, we really do need an interstate system, meaning banking across state lines. Now, this was all very good for some, but it benefited some more than others. So we have this thing in banking called the discount window, where if I'm a member bank, can access capital at significantly less than you can, a traditional person or bank. When you look at the history of all of that, and I won't explain it all because it'd take too long, but when you look at the history of how we went from intrastate banking to interstate banking, and today what we went from 22,000 banks to about 6,000 today. Okay? That's the same playbook as the Affordable Care Act, as healthcare consolidation in the hospital side.
For hospitals, yeah.
And so the answer to your question is, I don't know, but the evidence points in that direction, because when you look at who the architects were, they were bankers, Lazard. They were bankers, Goldman, Morgan Stanley, and they had a model. And so if you asked me as a young guy back then, well, let's say I was going to bring forth, the ACA, what would I do? Well, I've read history. Most guys that go to Ivy League schools are history guys, right? They're history guys first, and then they're MBAs or lawyers second. And so it would just be a natural thing to pull from other industries. So whether they did it on purpose or not, I can't make that assessment. But what they certainly did was they adopted the bad consolidation of financial services, banking history, and they put it into healthcare. And those parallels are just absolutely insane. If you've ever seen the parallels between John F. Kennedy and Lincoln, like how all those that's exactly how bank consolidation and the Affordable Care Act all came to pass. And so
if it wasn't for affordable care, which clearly it has not done any of the things that it said it was going to do, what was the ultimate goal then? I mean, if it's not to make it more affordable and to make it more equitable between doctors and patients, and it's only benefiting large institutions in the 10 groups that you started out with, what was the goal?
Let me just return to like what the Affordable Care Act promises were. If we can do that, then I'll get into that.
Sure, we can state them, yeah.
Yeah, I think first, we said that premiums would be reduced, right? That we said that was really important. So, in fact, the President of the United States said the average family is going to save $2,500 a year. And, of course, we all know that was a headline number. Number two, that access would expand. More people would be covered, and they'd be able to see the doctors they want to see. If you like your doctor, you can keep your doctor. I get in trouble for putting that on X all the time. Third, quality of care would improve because the system would be more coordinated, of course, more efficient, more accountable. And these promises were made to what you said, 270, 300 million people. And so I think anytime I talk about the ASC, I just start with what were the three promises that were made, and then let's let's break them down from there. But importantly, or more importantly to your question is, if that's what they were designed to do, and we didn't get those things done, then what was the purpose of the ACA?
Well, it doesn't appear that the way they set it up would ever have a chance of achieving that. So if it clearly, so essentially it looks like a lie, and if it is a lie, because the way it's structured would never lead to that, what was the structural outcome intended to be then, in your opinion? These are all opinions, obviously.
Yeah. These are all opinions. We're having a great conversation amongst friends. The purpose of all consolidation is control. And remember, administrative states work on a process that people learn in political science called legibility. Legibility means I understand and can account for everything in a very simple and methodical way. Legibility is probably something like, if I could teach every doctor in the country that word, I would teach them, because when you frame everything in administrative law, in Stark, anti-kickback, the NSA, all the laws we deal with on a day-to-day basis, when you look at them through the frame of legibility, you'll see how it makes sense. I mean, the Prussians did it to the point where they said, and they learned their lesson, and I don't know how we haven't yet, but back then, they decided that all forests should be legible. So they replanted everything and tore a bunch of it down. And then it all went to muck, and things didn't work out. Trees started dying, plants started dying, vegetation started dying. All their vegetables that they were trying to grow started dying. Cows started dying, sheep. It all went to... And so they did this 100-year experiment, learned their lesson, and went back to, just let the forest be the forest. Well, the administrative state wants every physician to work for a health system so that it can be put into a legible format. When you've got a decentralized state, which is what we have with about 160,000 doctors left over in independent practice, they want to account for you. CMS wants to know what Dr. Mandel's doing. And they don't like it that he's just off doing his own thing, experimenting his own way, and figuring out how to run his own practice and taking care of patients his way. That's not what the administrative state does. So I believe that the purpose of the ACA was always to put everyone in line and under the control of the United States government. I tried to say that in a non-conspiracy theory way.
And so that, to me, that sounds like they wanted single payer, which is the United States government. That's what it sounds like.
And that's the ultimate control, right?
Yes.
The ultimate control would be, there's one payer, it's us, and you do what we say.
Yeah, can you imagine? That's nuts. Can you just imagine?
It doesn't sound very American, does it?
No, it's very the antithesis of America.
I mean, I totally get that there are some things built into the Constitution that do make it a little herky-jerky, like you got 50 states, so you have the 50-headed monster of Blue Cross Blue Shield, where it's difficult to kind of to consolidate and do unified healthcare across the states. And every state's, you got its own licensing authority, and it makes it a little bit herky-jerky. So I get that, and that's also a parallel with the banking, right? You can't go in between states. But I also don't think that the knee-jerk reaction is then to unify it under one incredibly inefficient, expensive poorly delivered healthcare system run by the government. I mean, the government's never really shown that it's been able to do things better than private. So,
well, and I also think there's probably another question that I would pose after single payer is, what's the purpose of single payer? Is the purpose of single payer control? Is the purpose of single payer better healthcare, or is it more grifting for the political class?
I think it's all of those things, actually. I think you could make an argument that's the patchwork that goes into single payer, is all of those pieces of it. It gives credence to everything that you just listed.
24 months ago, I didn't know anything about Medicaid. Nothing. I mean, very little. Probably more than most, but not really. And then when you look at the amount of fraud that has gone on in Medicare just in the last 12 months that we've discovered.
Well, they've only looked at one state really, and now they're looking at several others, and I think it's going to be even bigger. Actually, a very small state when you think about the player that Minnesota is.
Well, I've been complaining about the provider tax for some time. Physician-owned hospitals that are not participating in Medicare and Medicaid because they're not allowed to, they were built after the moratorium, must still pay a provider tax. A provider tax, for the audience, is somewhere between 3 and 6% of gross revenue that you must pay to Medicaid in your state. The Medicaid director in your state then takes that money, adds it, and says, no, this was used for Medicaid, and then uses the FMAP, which is the calculation of how we determine what Medicaid reimburses, and submits that to the federal government. Now, most states are at least at 1.5, if not 2 times. So it's a really wonderful grift, right?
Yeah.
If I'm a large health system with a Medicaid population, let's say I'm in Massachusetts and I even am the payer for Medicaid, then I can tax all of the people in my state. The governor will send that as a bill to the federal government, and then I get my money back plus a little vig. And so you go, is that fraud? Well, CMS determined earlier this year, sometime early January, that it was. Now, unfortunately, I'm like, sir, why don't you just eliminate that program today? And, he's giving the worst offenders, California, Illinois, Massachusetts, better part of 36 months to fix this problem. Other states, by the way, are also offenders. Like, there's no state that's not guilty, because all these Medicaid directors get together across the country and they go, hey, how can we rip off the federal government? I.e., how can we steal from the taxpayers? And they all do it. And so just some did it more than others. California was, massive. And people wonder why the great governor of California wanted more people on Medicaid. Well, it was because the provider tax gave him huge amounts of $27 billion.
Well, that was also one of the ways that Obamacare was supposed to increase coverage, was to massively expand Medicaid.
That's right.
So when you find out that there's fraud going on in it, it almost seems like they were trying to feed into that fraud to bilk it more nationwide. I mean, that's what it seems like.
I think the difficulty with these kinds of discussions and the challenges is there's so much fraud and there's so much complexity. And I think when we talk about the ACA just ushered in these rules that so many physicians are so upset about, because it ushered in the ability of an administrative state to take control. So when I think about the ACA, that's its biggest issue.
Talk about that, though, the Dutch. Talk about the administrative state. How did it expand? I mean, there are numbers associated with it. Back when I was training in the early 90s, I went to med school in 93. None of that existed. There were very few administrators. Doctors were still relatively in control, but there was a war going on about it, and it was this was all sort of in the works. Hillary Clinton was trying to bring in her own form of health care as the first lady, and so. What happened to the administrative state and the ratio with doctors over the last 30 years?
Yes, there's a wonderful chart that I'm sure you've seen on social media. I would ignore that one. It's not. It is an exaggeration of the facts, which doesn't help our case.
No, it's good. It's good to bring it up though, and get some facts.
Yes, it's always popular. You'll see somebody getting 40,000 likes for it. And you go, do you need me to be the putz to explain to you that yes, it is true. We do have an administrative state. Administrators are terrible. I don't like any of them. I've found like 3 that I get along with somewhat, but at the most part, I don't like them and don't need them and don't see a need for any hospital administrators. But you mentioned the administrative state. Well, it grew, right? And it expanded. And somewhere 94, 95, it kind of started on the up and comings. But once we got through 2010, the administrative state had really taken charge. And so what I mean by administrative state is there's 5 large lobbying entities that control healthcare, whether it's pharma, med device through AdvaMed, AHIP does insurance, the American Medical Association, and the American Hospital Association, or the Federation of Hospitals, right? The Federation's pretty small, but American Hospital Association is big. The interesting dynamic of this is all of these groups started out as well-intentioned, good groups, and most of them started with physicians, right? Doing the right things for patients. It always starts that way, right? And then it's kind of like the income tax. It started with 1%. Like we're doing this to kind of
1% flat.
We're going to defend the nation, and now you're like, well, how much am I paying? I don't even know how much I'm paying.
Within 10 years, you had a 90% bracket at some point.
I think 2004, since we talked about facility fees, was a big year for me. It was really when site of service arbitrage became popular. CMS endorsed it. They started actively creating fee schedules for hospitals, for HOPDs, and for ASCs. And so now you saw an ability for someone like me who has some financial understanding to say, wait a minute, I get $1.50 if I do the procedure inpatient, and I get 50 cents if I do it at an ambulatory surgery center. How do I get all my patients to be inpatient? Like, how do I do that? Oh, I know what I can do. I will take Dr. Ben and Dr. Lee, and I'll buy their practices and I'll buy their ASCs, and then I'll turn those into HOPDs, and then I'll have some relative value units that are valuable to me on the inpatient side, and I'll write your employment contract so that you put more people inpatient. I mean, this is how this stuff works.
Yeah, I can tell you, I see that all throughout Florida. It's crazy, crazy, crazy. I have patients that will go to, quote unquote, the outpatient center for the local university hospital, literally 50 miles from the local university hospital, in a building no different than the building my practice is in. They see a doctor there, and they're getting charged, or the insurance company is getting charged, exactly what they would get charged if they were actually at the university hospital.
Yes.
No increase whatsoever in their overhead.
Could you define HOPD though, guys, for the audience? So what is an HOPD? And we know what an ASC in a hospital is. What's the HOPD? Just so everybody knows what it is.
Hospital outpatient department. So it's an ASC but attached to a hospital. And
so you therefore can get the money that a hospital would typically get, even though you're an ASC.
That's right.
And they've expanded that not only to ASCs, but to actual physician offices. Yeah.
You know who got that through is UPMC. They really push hard on the lobbyists. They make a lot of money. They get a lot of nonprofit cash. So they hired a bunch of lobbyists, and they pushed that through. I mean, imagine you're in Pittsburgh, and then 2 hours south of you're still getting a facility fee because you bought an ophthalmology clinic. Like, okay, come on, man. Like, does this make any sense? No.
So let's step back for a second and talk about how this all is affecting the patient. Okay, we've talked about a lot how it affects the physician and how difficult it is for the physician to practice under these guidelines and under these rules. But how is it affecting the patient? Obviously, we know that it's affecting the increase to access didn't happen, the decrease in premiums didn't happen, and I think the thing that's lost also is that the best of the best don't want to go into medicine and become physicians and surgeons anymore. And Ben and I talk about this all the time. Who's going to take care of us when we get older and need someone?
Well, they're also shortening the medical education too. I mean, the amount of didactics that physicians get is dropping off precipitously. So we went from 2 years of didactics to 1 and even 6 months at some formerly prestigious facilities. So we're definitely gutting the way physicians are produced, but also we're gathering people that are not quite as maybe on the same level as they were before, because there's no pay at the end of that. You work really hard, you go through your education, you come out, and your pay is in the gutter. So to Lee's point, the best and brightest are going into administration, and business, not medicine.
Absolutely.
I don't feel like I have a comment for that. I feel like that just is a wonderful standalone.
I think it's just
and we should just leave it.
Silence.
Yes, right.
And a sip of whiskey.
I feel like when people say really good things, you should just be quiet for a moment and just let it settle.
Let it settle.
Because it's really true.
Yeah.
We don't do it enough. I think one of the things that I love about these types of podcasts, certainly yours, is how do you help physicians become educated? I guess the first question you'd ask is, why do the physicians need to be educated on the healthcare system that exists in the United States? And then to what extent? I mean, it's something my dad used to say is, son, you'll understand when you're older. And I used to think, well, my God, man. I mean, I can read a book. And I think understanding comes through experience, wisdom, and time, right? It's duration. How do I explain to everyone what a $275 billion advantage looks like? So you're an independent practice, you're doing everything you can, but you got to compete against the couple of the health systems in your town. And as Dr. Mandel just said, they're getting paid inordinately more than you are. So I won't say the name of the academic center in South Florida, but when we had an office in Miami, and what we started understanding was, for the self-funded employers we were helping, is they were getting 625% of Medicare. Some of the smaller systems, Jackson Baptist, were getting somewhere just north of 300. And then our independent docs were getting 175, 180. And you just look at that, and then you have to help physicians understand, no, 660 of inpatient hospital fees, which is a different calculation than your 170 of normal physician fees, right? And so now you have to begin to understand the complexity of all the different fee schedules that CMS has, all the different fee schedules that commercial guys have, because they are not equivalent. You need a master map. And so how do you explain that? And then do doctors need to understand that? Or is it so overwhelming that you just go, I quit? Because there's days I wake up and I go, I don't want to fight this fight anymore. I mean, 340B, what a wonderful program, designed in 1992. Again, it started off very innocuous, very innocent. We are going to help. You hear President Trump talking about it now. Hey, what we're going to do is we're going to lower healthcare by lowering pharmacy and lowering those prices. Right? I'm going to do it through a forced mechanism. It's not one that I endorse, but it's through forced mechanism. That's what 340B was. Hey, we're going to give people access to the pharmaceuticals they need at subsidized prices. Right? Or maybe you and I would call them real market prices because they're super low. Well, then instead of, at that time in 1992 until 1998, maybe until 2000 when President Bush came in, we passed those on to the patients. Right? We passed the discount on to the patients. We were ordered by the federal government to keep the margin fixed that we'd had before. So if a drug had a margin of 28%, you weren't allowed to all of a sudden make it 280%. Well, after President Bush came into office, those rules changed. Right? The lobbyists came to D.C. and they changed. So today, I mean, you got somewhere around $75 billion of 340B that's collected by the largest 195 health systems that you as independent physicians can't collect. Right? You write scripts, but you have poor patients that don't make much money, and you want to help them, but you can't get access to 340B. So why? Why can't you get access to certain Medicaid programs? Why can't you get access to DISH? Why can't you get GME discount? Like, why can't you train residents? Like, I don't think academic centers do that great of a job. Why can't large independent practices or independent practices that meet certain criteria, like anesthesiology, do you really need to be around a program with 3,000 anesthesiologists at a large system? Or what about you just hang out with a group of 50 or 20? I mean, most interventional pain guys are anesthesia. Like, why can't you go to a large network of interventional pain guys and just rotate around the country and learn from them? And why can't they get the GME reimbursement for it? Like, these are all structural issues that, we collectively, the three of us, talk about a lot. And yet they all flow to health systems. And part of that really goes back to the root, which is the Affordable Care Act. Like, where did this money come from? Where did the lobbying efforts get so strong and so powerful? Because what you realized through the ACA was that lobbying works. Lobbying puts money in the pocket of the lawmakers, and the lawmakers are incentivized in a system where they need money to get reelected. Okay. Who's going to reelect me? Who's going to come to my PAC meetings? Who's going to come to my vacation in Florida, right? Who's going to come to the Ritz in name the place? And, well, who comes? Well, it's not normal people. They don't have $2,500 a night.
Well, we're not. The reason it's not normal people, though, goes back to Citizens United, right, Lee? I mean, the bottom line is that if you're calling money speech, and my ability to give money to a lobbying group or to a foundation is very different than a massive organization worth hundreds of millions or hundreds of billions of dollars. They can give on an order I can't. The problem I have with Citizens United and money being free speech is that money then determines what is a good idea. Instead of actually debating ideas, you see who can give more money, and suddenly that idea gains more weight. And so that's why I believe I'm seeing on the political spectrum, I'm seeing people arguing things that don't make any sense from a forensics, from a debate aspect. Those ideas were put forth because of money, not because of merit as an idea. And that's trickled into healthcare. Again, you look at the timeline. It was January of 2010 that the Citizens United was handed down by the Supreme Court, and then in just 10 months, you had suddenly a massive increase, $260 or $270 million. We can correct that if we need to. That went into both sides of the aisle. This is not a Republican or a Democrat thing. Massive amounts of money went into it, and lo and behold, the ACA became a good idea. Nobody knew what was in it. When they were asked candidly, political groups and pundits and senators were saying that they wanted it, but couldn't answer a simple question as to what was in it. What was this idea that suddenly became such a good idea? Well, it was money.
Yeah, and to your point, follow the money has permeated our entire society at this point, right? And healthcare was maybe one of those last bastions that really got taken over. So I want to actually close out the episode because we went through some great stuff on the ACA in this episode, and the next episode with Dutch, we're going to talk about, well, what can we do to change things? What can we do to actually make it better? But I have one story to end with. So I'm sitting in my office and I see a patient a few weeks ago, and the patient had seen another ENT in the community, 18-year-old girl. She has a large tumor in her cheek sinus, in her maxillary sinus, and she's told that it's probably a cancer, and she's sent down to the local university. Local university says, oh, yes, definitely. Looks like it's probably a cancer. We're going to have to do a big surgery. And they go ahead and they try and get authorization for the surgery. Well, the insurance company, I'm not going to name the insurance company, goes ahead and says, yeah, no, we're not covering it. And they get back to the patient's mother and they tell her, okay, well, insurance company won't pay for it. It's going to cost you $100,000 to have this procedure at our university. They go back. to the original physician. The original physician writes a strong letter saying this is the only place in the world that this can be done. They must have it done here. The insurance company says, no, that's not true. Send it to Dr. Mandel. He can do it. Patient comes to me. I look at the scan. I have no indication whatsoever on the scan that this is a cancer. I do the procedure. It takes me about a half an hour. It ends up being benign, and she's good. This is the problem, right? This is the problem. So, Dutch, this was a great, important conversation. I'm so grateful for you being on with us. Appreciate your laying out things so succinctly and really diving into some of the things that really most people don't even think about. So we're going to end the episode here. And to our listeners, thank you so much for joining us for this episode of Vital Discourse. If this conversation gave you a new way to think about things, the structure of healthcare and whatnot, share this episode with a colleague, share this episode with a friend, and we'll see you next time for myself and Dr. Ben on Vital Discourse.